Hello, and welcome to the professional webinar from the Christopher and Dana Reeve Paralysis Foundation. I'm Nurse Linda, and I wanted to just remind the viewers today that we're here to provide information, education. We can't give information about your individual specific concern. You can write in your concerns. We can only provide suggestions of this is what you might want to try, or this is something you might want to do. But always please ask your own personal healthcare professional if you should be doing or what you should be trying. We hope to give you suggestions so that you have information that you can go and ask questions about to your health professional, but we can't really say this is what you need to do in your own unique life. So I just wanted to remind you of that. Today we're talking about bladder issues, concerns, treatments, all kinds of things bladder. As I said earlier, I have found a person who can actually talk about the bladder more than I can. So we're set for today. It's going to be delightful. So our guest today is the Director of Spinal Cord Injury Rehabilitation and Recovery and the Director of Spinal Cord Injury Research at MedStar National Rehab Hospital at Georgetown University. She is also President of the American Spinal Injury Association, and I showed her I have my pin from our last meeting that I like to keep on my desk. It reminds me of all the people that the organization helps, all the scientists, researchers, and clinicians that go to these meetings wanting to learn things that will better help our patients in the hospital and in the community. And so today I present Dr. Suzanne Groah, MD, MSPH. Welcome, Dr. Groah.
Thank you. Thanks for that nice introduction.
Oh, it's lovely having you here today. I've been looking so forward to this. So the first thing I like to ask is just a general questions of how did you get started in rehabilitation? And then within that, what made you say, I'm really going to specialize on that bladder?
Yeah, well, I started in rehabilitation in medical school. I didn't know I wanted to go into rehab, but I did an elective because I heard it was fun. And during the elective, I got the opportunity to work on the spinal cord injury unit. And at that time, I was in medical school, so I didn't know what I wanted to go into. I was thinking of orthopedics or family practice or neurology, because those were all my favorite things. And lo and behold, when I was working with people with spinal cord injuries, I realized that this is a combination of everything I loved. Incorporates the neurology, the orthopedics, but then probably my most favorite part is I get to follow people and work with people throughout their lives. And so I really get to develop meaningful relationships with them. And then UTI or bladders. So when I started at National Rehab Hospital in 2002, I was running the spinal cord injury program, but also the research program. And we did research on a number of things, lots of secondary conditions after spinal cord injury. We looked into cardiometabolic disease, exercise, bone health, and some other areas. And then just really stumbled on urinary tract infections. And it's kind of a funny story. I don't even know what we want to go there, but I was basically just having a conversation with a researcher in a totally different field. And we were trying to find a common place to work together. And we couldn't find a common place. And he said, what's one of the most biggest problems for people with spinal cord injury? And I listed a couple, but one of them was urinary tract infection, neurogenic bladder. And we decided to start doing research together at that point, and that's pretty much my focus of research now. Not exclusively, but mostly neurogenic bladder and urinary tract infections.
So let's talk about neurogenic bladder, because I'm sure a lot of listeners are really interested in hearing that. Now, there's been a title change in neurogenic bladder that we've slimmed it down to neurogenic lower urinary tract dysfunction. So could you talk about what neurogenic bladder is and why we've had this title change?
Yeah, I mean, I don't know that I'd agree that we've slimmed it down, because neurogenic lower urinary tract dysfunction is a mouthful in and of itself. So it was just a change to better represent when we're talking about neurogenic bladder and addressing neurogenic bladder, that it's not just the bladder. It's also the bladder neck, and it's also the urethra. So that's really the lower urinary tract. So it was really to be more precise in talking about neurogenic bladder. A lot of times I kind of flip back and forth between the two because a lot of people don't know what NLUTD is, and then there's not a good way to say it, like enluted or something just doesn't roll off the tongue. So it's just really to better encompass kind of the anatomy.
So talk about neurogenic bladder and the anatomy. What goes on with all of that neurogenic bladder?
Well, so neurogenic bladder is some dysfunction of the bladder because of an issue with the neurologic system, basically. So people, what I tell people is neurogenic bladder. So for simplicity and just rolling off the tongue, I'm going to say neurogenic bladder and neurogenic lower urinary tract dysfunction are synonymous for the purpose of our talking today. So it's really a spectrum, and it can be very different for different people. So the spectrum varies from, the neurogenic bladder that can't empty on its own. Or the person can't empty voluntarily. So that's what we call urinary retention. So that's one end of the spectrum. The other end of the spectrum is that bladder that really can't hold urine very well. So there's a lot of incontinence. So it's the other end of the spectrum. But then there can be a lot of mixing in between. There can be components of both. Some people can have retention and leaking. And then there's a couple other things that go along with it. Like I said before, one of the reasons for the nomenclature change, the naming change to neurogenic lower urinary tract dysfunction, was to better encompass everything that's involved. So it's not just the bladder, it's the bladder neck, and then the urethra as well. And they all have to work in combination. So what I tell people is the bladder is a muscular vessel. It's designed to hold urine, and then it's designed to empty urine when you want it to. So it's a muscle. It's designed to stretch out, and then it's designed to compress down. But there's also a door. That's sort of the bladder neck and the sphincter. So they have to work together. When the bladder's filling with urine, the bladder needs to relax and stretch out, not contract, right? But the sphincter at the bottom, which is at the top of the urethra, is the sort of the exit way out of the bladder. That sphincter holds tight to help hold the urine in there. So the bladder's relaxing, the sphincter's tightening. And then when you want to go to the bathroom, the sphincter opens up and the bladder contracts down. Now, with neurogenic bladder, sometimes those don't work in combination or in a coordinated way. One doesn't relax when the other contracts and vice versa. Sometimes they both contract at the same time, and we don't want that. That's a condition called DSD, or detrusor sphincter dyssynergia. So what's happening is the detrusor, or the bladder muscle, is contracting at the same time the sphincter is contracting. And then we worry because then the urine gets to the bladder from above and behind, from the kidneys, through tubes called the ureters. If both muscles are contracting at the same time, the urine might go back up to the kidneys. And we don't want that, because then there's potential to damage the kidney. So there's this whole spectrum that can be different with different people. And I think the other really important thing is neurogenic bladder is not stagnant. It changes, and it can change. And as such, kind of bladder management should change sort of through life, and maybe reacting to different things.
So how do you diagnose this?
Neurogenic bladder?
Mm-hmm.
So, very simple. The simplest way to diagnose this, which is obviously not the most precise, is a clinical diagnosis. A lot of times I will diagnose a neurogenic bladder in an individual who I see, who I know has a spinal cord injury, and I diagnose it based on their symptoms. I can't empty my bladder, or I empty my bladder every hour, and even when I do that, I leak in between, or I can't really feel when my bladder's full. So again, a variety of symptoms, but really the precise way of diagnosing neurogenic bladder is with a test called Urodynamics. And that's a test that is done in the office, and electrodes are attached to different parts of the anatomy that we've been talking about. Sort of the belly, the abdominal wall, and then around the rectal area, and then fluid or saline is injected in the bladder and pressures are measured. And then we see how the different parts of the system are working together. But that's really the way to kind of very objectively diagnose it.
And then if you get diagnosed with this somewhere on the spectrum of the neurogenic bladder, what kind of treatments would be available?
So the treatments are really variable depending on your symptoms. So I gave the examples of the opposite ends of the spectrum. So if someone is totally retaining urine, like they can't empty urine at all, we don't want that bladder to become overfilled. That's dangerous for the kidneys, and it can become painful, and again, it can become dangerous. So we will often use, the most common approach is to use a variety of different kind of catheters to help empty the bladder. There are medicines that help empty the bladder. And so if someone is retaining urine to a certain degree, but they can go to the bathroom on their own as well, they're just not going all the way. For example, many men have larger prostates and they have trouble emptying their bladder all the way. We do have medicines to help that out. So when someone's sort of partially retaining, the medicines can help. If someone's totally retaining, we don't have medicines good enough just for the medicine to do the trick. So usually with catheters. Then if we have someone on the other end of the spectrum who's leaking a lot, then we kind of look at different things. Why are they leaking? Are they leaking because that bladder muscle is not stretching out and they can't hold a lot of urine? Are they leaking because that bladder muscle, so this is a very technical term I use with my patients, is twitchy? It means even when there's a little urine in there, it tends to twitch and expel a little urine. Or are they not able to hold urine and they're incontinent and have leakage because of a problem with the sphincter? So we have to look at all those. And that's where that test Urodynamics really comes in handy, because it gives us a lot of information there. The approaches sort of for that end, we do have some medicines that can help out, especially with the bladder. We have bladder relaxant medicines, a number of those. We don't have great medicines to tighten that sphincter up, but there are some surgical procedures to help there. So, and then again, many times we have a combination. So the treatment approach might be a combination as well. It might be a combination of medicines, catheterization, maybe surgical procedure, those kind of things.
Now, for the physical therapists that are tuning in, do you have any suggestions for some therapy that might accentuate some of this care that's needed?
Yeah, that's a great question. As I was finishing that last answer, I was realizing that, I left out an important piece. So I think in the past, we haven't really pursued that very good option of physical therapy, but it's becoming much more common now. And I'm getting my patients, especially those on the spectrum we just talked about at the end, who tend to be leaking, involved in pelvic therapy. And so pelvic PT. So what are the kinds of things that pelvic PT might be able to accomplish? And again, I think it's those people that are more on the spectrum where they tend to have leaking and incontinence. So there can be biofeedback, there can be electrical stimulation, manual therapy to help people be able to do exercises at home and tighten down their pelvic floor muscles on their own. So the pelvic floor muscles are muscles that are kind of go across the pelvic floor, kind of right under the bladder, but across sort of where that urethra, that tube exiting the bladder is. So if we can tighten those up often, we can promote continence and kind of stop that leaking. So there's like I said, there's a number of exercises, biofeedback, manual therapy, electrical therapy. There's a little bit of research going on right now, which I think is really exciting. And there's a group looking at abdominal strengthening, or core strengthening rather, and co-contraction of that pelvic floor at the same time. So if someone's in, for example, pelvic PT, and they can't seem to really get that contraction of the pelvic floor, or they can't feel it, but maybe they can contract their core. There's some evidence that when they're contracting their core, they might be contracting that pelvic floor as well. So that might help. So that's new, but I find that that's really exciting as well. So there's definitely a role for therapy.
So lots of things are going on in that treatment phase as well. I want to skip back just a little bit and ask one question about urodynamics before we move on. And there's been some, I wouldn't call it controversy, but there's been some changes in the thoughts about urodynamics, where it used to be recommended every year you go and have a neurodynamic test. Now people are saying, well, you know, we do the test, everything's fine, maybe you don't need to have it every year. But yet, as you said, you can evolve and the neurogenic bladder can change over time. So you don't want to completely just skip it forever. So what are your recommendations? What's your algorithm for having urodynamic testing done?
Right. So, and the American Urological Association just came out with kind of new guidelines for neurogenic lower urinary tract dysfunction, I think at the end of 2021. And so so flashing back, like you said, so let's flash back like, I don't know, 20 years. Recommendation used to be get urodynamics between roughly 6 months and a year after injury. And then, yes, you get it at repeated intervals. So we've realized one thing, that there's some elements of neurogenic bladder, particularly the ones we're worried about, the detrusor sphincter dyssynergia, that may actually be kind of silent, but happening earlier. So we are kind of recommending now to get the first urodynamics a little bit earlier, like ideally maybe around 6 months or so. That one is mainly to really look for, is there some silent detrusor sphincter dyssynergia going on in there that we should know about? Now, beyond that 6 month period, yes, the bladder still may change. And one of the reasons for change is we know that there's actually nerve sprouting that happens in the bladder remotely after injury. And that's probably part of the reason why we see a change over time. So after that 6 month-ish first urodynamics, which also sort of guides care, basically, there's no need to get urodynamics, in my opinion, kind of more than about every 10 years. And I believe, now I have to look at this because I don't know this one off the top of my head, but I believe what the American Urologic Association says is an initial urodynamics and then urodynamics as needed after that point. So we're not recommending at this point annual urodynamics anymore, for sure.
Okay, so, but continue to follow that along, because that's
Continue to follow and based on symptoms. And if you notice a change, and one thing so this is what we see. People may get on a bladder management program. So for example, intermittent catheterization, be totally fine. And then after a period of time, they develop some leakage or they develop bladder spasms. So at that time, so that's a change. And it would probably warrant a change in care, maybe addition of some medicines or something like that. But that would warrant, in my mind, probably taking another look at the urodynamics as well to help guide the care.
okay. So kind of skipping stations here, but staying in the same zone, urinary tract infections. There's already some questions that we have rolling in on that. It's a particular issue for people with paralysis. So what's your approach to diagnosing and treating urinary tract infections?
So much of my research now is on urinary tract infection. So I started this around 2012 and wrote our first study. And we were writing the grant proposal on urinary tract infection. We were almost done. We're almost submitting it. And then as I'm writing it, I realized, how can I write this on urinary tract infection? Because honestly, we really don't know what a urinary tract infection is. So here's my spiel. I kind of tell people is that it is mind-boggling because urinary tract infection is the most common outpatient infection worldwide. Everyone living on the planet, most common outpatient infection. It's the most common, what we call healthcare associated infection. So infection of people in the hospitals. We all know that catheter associated urinary tract infection is a big problem. It is also arguably the most, well, it is the most common infection among people with spinal cord injury and disease. And it's arguably the most common cause of going to the doctor. So it's a huge, massive problem for people with spinal cord injury and disease and the general population worldwide. So the mind-boggling thing is we do not have a good clinical definition of UTI for people with neurogenic lower urinary tract dysfunction. So the infectious, so as physicians, we use guidelines. So the Infectious Disease Society of America has guidelines for UTI. The problem is they're for all people who use catheters, and they're really geared for people with indwelling catheters. Now, there are a couple other groups that have guidelines as well. Back in the early 1990s, NIDR and IDRR put out an expert consensus statement for guidelines for UTI. Problem is those don't match up with the Infectious Disease Society of America. And then there's been a couple of research groups who have suggested guidelines for UTI. So how do you diagnose it? And nothing matches up. So I have a table in my research that I call the magic table. I take all these urinary tract infection guidelines and I put them all beside each other. And it just looks like a bunch of holes in the walls, because if they matched up, you would see a match across, but you don't. So let's take a step back. Right now, where we are, we consider there are 3 pillars that constitute a urinary tract infection. Those are symptoms. So you have to have you have to have symptoms that are really specific to the lower urinary tract. Inflammation. So inflammation, irritation, that's typically measured through white blood cells in the urine on a urinalysis. And then what I call bacterial growth. So that's where we use the urine culture to see if there's bacterial growth there, if it's in an amount great enough that we would call a urinary tract infection, even though we're not really sure what that amount is. So just remember, we do not know definitively what a UTI is in the spinal cord injury disease population. We're still going to rely on those 3 pillars, though, because that's the best we have right now. And just to let you know, we are doing a study right now. We have a 5-year study that's ongoing. We're in our 2nd year where we're trying to define this problem. So it's called the CUTI study. So it's called complicated UTI. So it's CUTI. And the whole purpose of this study is to develop actually diagnostic guidelines. So, and then guidelines for people with spinal cord injury and disease, so they know what a UTI is. So but what's my approach? Because I still have to approach it at this time, even though we don't have an answer. So we've spent a lot of time, like the last 6-8 years, really looking at urinary symptoms and coming up with measures. And I know that's not important for people living with spinal cord injury and disease, but it's really important for research, it's important for clinical care. And we're just now translating that. So it's important for people living with spinal cord injury and disease. So what we've done is We have developed measures for urinary symptoms and basically decision algorithms over the combination of symptoms. So for example, if someone has cloudy urine and that's their only symptom, we have a decision algorithm, which is try to drink more water. If someone just has belly pain and nothing else, nothing specific to the bladder, we have sort of a decision algorithm for that. So, you know, we don't think you need to go get evaluated for urinary tract infection right now, but monitor it. Now, someone has someone uses intermittent catheterization to manage their bladder, is having leaking between caths and either increased spasticity or a fever. Okay, though that combination is sufficient enough where we suggest you go and get evaluated for a urinary tract infection. Or one other sort of major decision point is person just has a fever, but no other symptoms specific to the bladder. Okay, could be a UTI, but we don't have any symptoms specific to the bladder. You do have a fever, so you probably should have that evaluated, but we're not really sure what it is. So we've done a lot of work in those decision-making algorithms, gotten that published. So we're doing work right now, putting together an app where people can actually plug in their symptoms and it'll help give them the decision about what to do. And it's always an individual's choice, right? If they feel uncomfortable with that choice, you do what you're comfortable with. So we're building that app right now for people. We have it kind of right now, and we use it in our research in papers, but like paper format rather. But I think an app will just be a little bit simpler. And then what we hope to do is, as people use that app, we'll collect the information and then refine it as we go. So that's one of my approaches. And so, you know, from a clinical standpoint, I kind of have a little gestalt based on that. Very, very similar to the examples I just gave. So someone first needs to have symptoms. That's pillar one for a UTI. And then they have to have inflammation. So there's irritation in the bladder. It's usually measured, as I said before, through a urinalysis by looking for white cells. The problem is many people, I might even go so far as to say the vast majority of people who use any type of a catheter to manage their bladder, either an intermittent catheter or an indwelling catheter, have inflammation even when they don't have symptoms of a UTI. So that pillar becomes a little bit hard to use because it's there most of the time anyway. And then the third pillar is bacterial growth. So is there enough bacterial growth on a urine culture for me to say, that bacteria is causing the problem? Well, there's a problem with that too. So we've been taught, and I think medical students are still being taught, and I was taught, that the bladder is a sterile environment. So there shouldn't be any bugs in the bladder at all. Urine is sterile. Well, so back in 2012, this was our first research project, actually, the one where I had a conversation with the other researcher, and we decided to do research again. We took a whole bunch of urine samples of people who did not have neurogenic bladder and people who did have neurogenic bladder. We just grabbed the urine samples and we ran them through a DNA sequencer, and we looked at DNA. And what I was expecting to see was the people with neurogenic lower urinary tract infection would have bacterial DNA in their urine. I mean, that's kind of what we were taught clinically. Once you have an indwelling catheter for 7 days, we know that you get bacterial colonization in the bladder. So we expected that. And then what I expected, because of what I was taught in medical school from the non-neurogenic bladder population, was that we wouldn't see any bacteria at all. Well, that's not what happened. On the first case, it is. In the people with neurogenic bladder or neurogenic lower urinary tract infection, yes, we saw bacteria, and we saw the ones that cause people problem. E. coli and Enterococcus and Proteus and Pseudomonas and Klebsiella. Yes, absolutely, they were there. But the population that was supposed to have sterile urine and not have any bacteria at all, they did have bacteria in their urine. And it was a lot different. It wasn't those same bugs. It was actually, and one bug we found only in the people without neurogenic bladder. And we did not find it at all in the people with neurogenic bladder. And that's lactobacillus. So that was the big surprise. And at the same time, a colleague who I work with now, Alan Wolf at Loyola in Chicago, was doing a similar study, not on people with spinal cord injury, but in postmenopausal women. He also took urine samples and basically did a very similar study. Took urine samples of postmenopausal women who had stress urinary incontinence, so they had leakage, and then took a group of postmenopausal women who didn't have any leakage. And guess what? The ones who didn't have any symptoms, who didn't have any leakage, they had a lot of lactobacillus. And the ones who did have leakage had less. But at the same time, they also found bacteria in this environment that we had all been taught was sterile. So there's a couple of really important things that came from this. What we were taught in medical school and what's still being taught is not true. Urine's not sterile. And the really important thing about that is when we're taught something is sterile, we want to make it sterile, right? We want to make it clean. So when we see bugs one way or another, we want to clean it up and make it clean. So we need to totally change our thinking about it. There is a bacterial environment in the bladder, in everyone's bladder, and it's probably changing, and it's different among people who have neurogenic bladder and don't have neurogenic bladder, but it's there. So if we find bacteria in the urine, that in and of itself is not enough for us to wipe it out and make it go away. So my approach to UTI is to do a whole lot of research and try to like fill in all these gaps where we need answers. Like we need better diagnostic guidelines because we don't have diagnostic guidelines. So we're over-treating, we're giving way too many antibiotics. We've done a ton of research on urinary symptoms. So that's, and that decision-making is just about to be launched now. So it can really be used. So that's really great. Now we're really doing, and we have done a lot of research, doing more genomics and DNA studies on the bacteria that are living there. So my approach and my research is not to wipe clean the slate of bacteria in the bladder, but understand there's a bacterial community. And that bacterial community in there can be living totally healthy and not causing you any problems at all. But it can get out of balance and cause a problem for sure. So my approach is, let's try to get it back to a balanced environment. Okay. So what we've been, and then remember, I talked about our early results where we found lactobacillus, right? And a lot of the people with very healthy functioning bladders, but to a lesser degree in those women who were having incontinence, but also in people with spinal cord injury and spinal cord disease who had neurogenic bladder. So what we started doing, and we got our first study in this funded in 2014, and we've been continually funded since then for this line of research. And I want to emphasize to people that this is not approved by the FDA. The FDA considers this experimental. I have a special approval called an investigational new drug approval from the FDA to do this in an experimental setting. So in our research, we are actually in certain situations having people, and we've expanded beyond spinal cord injury and disease. So many catheter users, basically either intermittent catheter or indwelling catheter, put lactobacillus in their bladder. So the beauty here is we have direct access to the bladder because many people use catheters. So we use the catheters to empty the bladder, but we can also use the catheters to instill medicines, saline, a number of things in the bladder. So we're actually trying to put that lactobacillus. It's called a, people use the broad term probiotic. That's really broad, and I know it's commonly used. So the new term coming out for this is a live biotherapeutic. So we're putting those live bacteria in the bladder with the hopes that what they do is they reconstitute and grow in the bladder and help prevent urinary tract infections and urinary symptoms. So we've got a number of studies going on right now. We finished our first one in about 2018, 2019. It was the very first trial, and we got good results, that it's safe and it was well tolerated. And that was the main purpose of that study. As a secondary purpose, we looked at kind of efficacy, and we did see some preliminary efficacy. So now we've got some two dosing studies going on, and we've got a large phase 3 clinical trial going on, using it in response to certain urinary symptoms, but then also prophylactically twice weekly.
Well, this is really important because this is such a new way of thinking, and I'm sure this is new information for a lot of people. So we are really going to have to keep up with you and find out what happens here, because when you describe it, it makes so much sense, you know, and you sit here and you think, why didn't anybody think of this before? But, you know, there is that evolution to get there, plus trying to surmount that. This is what we've been taught since forever. And that is really a difficult thing to get over. There's a couple of questions here about UTI, so I'd like to just kind of take a brief moment to skip over to those since we're in this topic. Here's a person, it's a female. She's been quad since 1979, C6 incomplete. She doesn't use a catheter. However, as she's aging, she's noticed symptoms of UTI, but the culture shows no bacteria. That's a common thing. She has to urinate frequently. She has pain and itching. She's taken azo, which did help, but the box says not to take it more than 2 days. Do you have any suggestions? Does she need to start catheterizing? I mean, we can't give answers specifically, but what can she think about?
So actually, the first thing I think about in this case is if the woman has gone through menopause, because a lot of these symptoms for women, once you have that pretty profound hormonal change with menopause, so the hormonal change leads to some vaginal atrophy, and that can cause itching then and burning and irritation. So it's really, really mimics urinary symptoms. The super interesting thing here is I was talking about so we call it the bladder, all the bugs in the bladder, they're called the microbiome. So the bladder microbiome, there's a very, very well-known vaginal microbiome. And guess what? Guess what the main bug in the vaginal, a healthy vaginal microbiome is? Lactobacillus. So when people go through menopause, it changes. And so we're thinking a lot of those symptoms can be related to menopause. So and can be lactobacillus related. So, and I am not exactly sure. I think there are actually commercially available now products, and I know there's some products in research as well, but there are vaginal lactobacillus products so it's a vaginal suppository basically, and they're pretty easy to use. And then some people use as well estrogen vaginal suppositories. So for those kind of symptoms, if the individual is kind of postmenopausal, I would actually pursue that angle first, before we necessarily jump to, you haven't used a catheter for so long and then all of a sudden needing a catheter. There might be kind of easier ways to approach this.
And would you consider perimenopausal also?
Yes.
Consider that if you're in that age range?
Yeah, because perimenopause can last up to 10 years. And so there's going to be a hormone change during that time. And especially if an individual, even if they're able to void on their own, they don't need a catheter, but they have some element of neurogenic bladder. And that's an important point too. Just because people don't need a catheter doesn't mean you don't have neurogenic bladder. There were a lot of don'ts in that sentence. People can have neurogenic bladder and void without using a catheter. So someone with a neurogenic bladder who has voided all their life, but they probably don't have quite the physiologic reserve. So you have a little bit of a change, maybe perimenopausal menopause, and that may be enough to really, as a result, have a bigger change in terms of symptoms. But again, I'd kind of first look at the sort of women's health issues.
And that's very logical. So that's really gives that person some food for thought there in different ways. So it kind of makes me feel more comfortable in the fact that maybe it's not the bladder issue at all, but it's tandem to the bladder. So you would think,
Right.
yeah, it's very close. So there's a couple of questions about antibiotics. One is antibiotics, EBSL with E. coli, and the other one, do you recommend gentamicin bladder irrigation?
So EBSL, so E. coli. E. coli is the most common bacterial cause of urinary tract infection. E. coli is a little devil of a bug. It multiplies really rapidly. It eats a lot, but there's also a lot of varieties of E. coli. There's a lot of E. coli that just don't do anything and they just hang out, and that we really don't have to worry about. But there are E. coli that we do have to worry about. Again, I don't typically react to the bug itself in the absence of symptoms or, a big change in inflammation. Okay. So I really try to tell people, don't just react to the bug. So let me tell you one other thing about the bug. In addition to, we don't have a good diagnostic guideline for what constitutes a UTI. I hate to tell people this, but the way we diagnose UTI using a urine culture also stinks. So, but it's the best we have. It's what we use. We're actually trying to develop better approaches to this. But what happened was way back in the 1950s or something like that. Pyelonephritis, kidney infection was a big problem. That's usually caused by E. coli. So there was a scientist who developed a culture to identify E. coli specifically for pyelonephritis. And it worked. It worked beautifully. It worked so beautifully that we decided to use it for everything urine. So we use that for our standard urine culture. The problem is that culture was designed to grow that specific bug, E. coli. We still use that same urine culture. What it means is that urine culture does not grow other bugs very well. It's really preferential to E. coli. So that's why I don't get too wigged out on a standard urine culture if it grows E. coli, because it's actually supposed to. And now I know, like when these urine cultures were developed, right, we thought urine was sterile, so nothing could grow in that urine culture. But now we know there are bugs in the urine. And now we have this urine culture that preferentially grows E. coli way more than any other bug. So we're going to get growth of E. coli on the urine culture, so I can't react to that because I know it's going to happen. So that's number one. And intravesical gentamicin. So in certain people, so broadly, I think our use of intravesical agents is way underused. So I love that question. There are a lot of things. So for anyone that doesn't know, intravesical is injecting it right into the bladder, but it's through the catheter. So you just use the catheter and attach a syringe to the end and instill into the bladder instead of draining the bladder. You can instill a number of agents. There's a number of antibiotics you can put directly in the bladder: gentamicin, tobramycin, imipenem, and neomycin polymyxin, different polymyxins, lots of antibiotics. You can put normal saline in the bladder. The beautiful thing is so there's been more work, more studies, and it's actually, use of intravesical gentamicin is way more common in kids for some reason than adults. I'm not really sure why. And so gentamicin broadly is a strong antibiotic that we give usually for systemic infection. So we usually give it IV. It's in liquid form. And it runs the risk when you give it IV of kidney damage and also the nerve that controls hearing. So we have to do hearing tests for people who are on gentamicin, and we have to check levels, and we have to check their kidney. So we have to be really cautious about that. Here's the beautiful thing about intravesical gentamicin, that now there's just been a couple studies, but it appears that it is not absorbed systemically when you put it directly in the bladder. So there's been a couple studies looking at kidney function tests and hearing tests. There haven't been any problems or safety issues in that regard. Now, we kind of guess at the dosing a little bit. So some people use it, they've had a lot of recurrent infections. Some people might use it, daily, every other day. Some people even use it weekly just to sort of prevent infections, but I do think it's underused.
Okay. Here's an interesting question in regard to the non-sterile bladders. There's a study at Duke University where they're supposedly working on a vaccine for UTIs. That kind of fits in our thoughts about what's new and different in bladder care. So any thoughts on that?
Right. I mean, I have heard of that. I actually honestly don't know the details, but it's exciting. And again, I don't know the details. So I kind of wonder, I'm like, what bug are they targeting? Because we do know that, when the bladder microbiome gets out of balance, it's the E. coli or the Pseudomonas or the Klebsiella or the Proteus or the Enterococcus, who tend to be kind of the bad players. So I kind of wonder, are they targeting one of those? Or are they targeting multiple? And actually, let me tell you one other thing that's interesting that you reminded me of with the vaccine. I had mentioned we're putting lactobacillus in the bladder. So we've done more work, and I mentioned my colleague, Alan Wolf, out in Chicago. So he's a microbiologist who is very, very experienced in working with lactobacillus. So what he has done is actually put lactobacillus and E. coli and some other bugs and Enterococcus and Klebsiella together in little, basically, petri dishes. And the lactobacillus actually physically kills, I'll just talk about E. coli for right now, physically kills the E. coli and other bugs. And it does several things. We don't know all its mechanisms, but we do know that the lactobacillus actually disrupts the membrane of those bugs that cause infection. So kind of blows them up. It also competes with their food. And it also, lactobacillus, they survive better in acid and also produce acid. And the E. coli and other bugs don't like that acid as much. So they're actually physically doing things that kill the bugs that cause infections. That's what you reminded me of with the vaccine. And actually, I'll tell you about one more thing that's super cool, because you mentioned a vaccine that's cool. There's also an investigator in Texas who is looking at phage. So phage is spelled Phage. It's very cool science fiction stuff. So they're viral particles. So they actually are looking at developing a cocktail of phage. So they take a urine sample and look at the bugs, a urine sample of someone who has repeated infections. Look at the bugs that are probably causing the problem, and they can develop phage, which are like viral particles, to attack those bugs. And then she's looking at using phage either in the bloodstream or in the bladder for really like recurrent UTI. So there's some, like, I've got one approach, but there's some very cool different approaches out there.
There's a lot of stuff going on in that regard. Here's we need to talk more about, we're getting close to, well, we've got about 10 minutes, but I want to talk more about things that are being developed. But this is a very important question that this person really needs an answer. The question is for someone who has a spinal cord injury, had a suprapubic catheter with severe spasms, and then it's in two parts here. So they tried several Botox injections and take medication to reduce the spasm with no avail. So they've been told that removing the bladder is the only option left. Do you have any other options that they could maybe pursue?
I do wonder like, I would think if someone is suggesting a bladder removal to them, they would have suggested also bladder augmentation. I mean, we do bladder augmentation, which is taking a piece of the gut, basically. And you sort of open up the bladder when the bladder is really contracted down. And again, a lot of these procedures are done for whatever reason. We think about them more commonly in kids. And they sew in some bowel to that bladder to make it a bigger bladder, basically. So that, I mean, it sounds very difficult and very challenging, but that's the first thing that kind of comes to mind for me. The other thing is another really exciting area of research. It's related to this problem this individual has. Another approach that's being used right now is neuromodulation. So different kinds of stimulation, like tibial nerve stimulation, so we use electrical stimulation down at the tibial nerve, which is down at the ankle, or epidural nerve stimulation. That's really geared toward trying to get that bladder to relax. So, and we do it a couple of ways. So there are devices that get surgically implanted into the body. So we use like basically a spinal cord stimulator device. So a stim device that many people use for different reasons, like for back pain or whatever. And then the electrode paddle in the array is placed on the sort of base of the spinal cord near the nerves that go to the bladder. And so spinal cord stimulator to kind of relax that nervous stimulation that's going to the bladder that's causing it to be so spastic and twitchy. So it's really for relaxation. So for example, and so I talked about it in terms of there's an implanted device, but then there's also epidurals, like transcutaneous epidural stim, where you don't get the device implanted and you put a large sticky electrode array on the skin on the outside. And that's experimental right now and it's new, but again, it's to promote that bladder relaxation. And then, like I said, too, the tibial nerve stimulation, which is down at the ankle. So those are, that's a lot of research that's going on in the country right now for that really overactive bladder issue.
And actually, there's a couple of companies, Onward and Spinex, which are going to have devices that will be coming out in the new year. So this is just like right around the corner. And it's not like it's coming out, oh, it's going to come out someday. No, it's coming out. So
no. All those trials are active right now. And if it makes people feel better, I mean, this kind of stemmed out of, for the last probably 8-10 years, this research has been going on, again, in women without neurogenic lower urinary dysfunction who had overactive bladder, and in some individuals in MS. So it's been going on for a while, but I think in spinal cord injury and disease, it's really like gained a lot of steam in the last few years.
Now, what would you think about a Botox implant, a Botox pump?
Well, so bladder, so this is what I tell my patients. Botox to the bladder.
Oh, I didn't mean Botox. I meant baclofen. Sorry.
Okay. Okay. So I'll just finish what I was saying. Bladder Botox, I just want to put it out there. That's been a game changer. There's been a few devices, a few discoveries, a few changes in our management that I feel have been true game changers for people. I feel like bladder Botox has been a game changer. It's really great. So a baclofen pump to target the bladder, I think is what you're asking. Mm-hmm. I don't know. I think in that kind of case, it's so specific and so nuancey. So this is the beauty though. We have a baclofen pump trial, right? So, for whatever reason, you're trying to, someone's considering a baclofen pump, you always go through a baclofen pump trial anyway to see if it's effective. So there is a way to do that. Now, for the sort of more typical use of a baclofen pump, which is too much spasticity of the arms, the legs, usually the legs, we sort of observe how someone moves during that 24-hour baclofen pump trial. So if anyone knows baclofen pump trial, we basically do an LP, lumbar puncture, put the baclofen in there without implanting any devices or anything like that. And so the baclofen goes right around the spinal cord, and we see how someone responds to that. So, and I'm just kind of like talking as I go right now. So for this particular case, what I imagine could be done is someone could have a baclofen pump trial and basically have a urodynamics right then. They could have urodynamics beforehand, and then a urodynamics while the baclofen pump trial is going on. And then they would really see what the benefit of it is on the bladder specifically.
That is really a clever idea. Are there any other kinds of things on the horizon that you really want to mention that would be new that we should be looking out for?
Yeah, I mean, so a big thing that I want to express is, like when I started writing these grants specifically on bladder and urinary tract infection, like 10 years ago, the intro to my grants was always like, there's been no change in neurogenic bladders in 50 years. And look, we're proposing this. There's a lot of things going on right now. So I want to really give people that encouragement. There's a lot going on. There are all the things we talked about regarding UTI, a whole different way of thinking about UTI, and as such, a whole different way of thinking about treating it and preventing it. There are new catheters people are looking at, new different kinds of catheters, reusable catheters. I mean, I'm working with a couple companies right now where we're looking at those. There's another company looking at a urodynamics device that can actually be inserted, and so you don't have to go to the clinic to do it. You kind of do it at home on your own, which, when you asked me the question about how often do we get urodynamics, well, if you didn't have to go to the clinic, maybe you do it more often. So, and then that could really be relevant for this individual you mentioned who's asking about a baclofen pump. Well, that might be the perfect time to put in this so we call it an ambulatory device, an ambulatory, so people don't have to be in the office, urodynamics device. So that's going on. So, and then there's the whole neuromodulation area, which we mentioned a bit, and not even for people with acute injuries, people with chronic injuries too, really doing some electrical stim to different areas, though, to the ankle implanted device, but also transcutaneous to really promote bladder function and improvement in bladder function. And then, of course, and I want to talk about this last, like new medicines too. So there is a lot going on now. Like, I'm really encouraged because there's action in this area.
That's really exciting. There's lots of things going on. So this is really a time just in all areas of, if it's spinal cord injury, paralysis, other kinds of research, it just seems like we're in a boom time right now. What are the 3 take-home points that you would like people to remember from this presentation, which has just been mesmerizing?
Well, thank you. I mean, so you asked me before about 3 take-home points, and I can't even limit it to 3. I would like say 10, but well,
okay.
I'm not going to.
In my book, you could go 20.
So the biggest thing is, because UTI is my big area now, turn your head around and think different. And I say this to clinicians too. I'm like, so I give these lectures to clinicians all the time, and it's now taking 10, 20 times people hear it and they're like, oh, we do need to think differently about this. So don't just react just to bugs. Bugs can be good. Okay. And we're hopefully gonna have some friendly bugs that will be able to help the UTI problem. Get to know your symptoms better. Not all symptoms in the urinary tract are urinary tract infection. The question that came up earlier was absolutely perfect. Could be in a postmenopausal female. It could be more related to hormonal, but that's a really good example. But not all urinary symptoms are urinary tract infections. So one thing we've learned from our participants going through our research is we make them fill out these long questionnaires on urinary symptoms. And a common comment that I get coming back to me is, it really helped for me to sort of write down those symptoms or check them off, because now I kind of get it better. And I don't worry about some things I don't worry about when my urine gets cloudy. I don't worry about if it gets a little darker certain days. So get to know your symptoms a little better. we're going to have decision making out there, so you can be more independent with your decision making. Think about putting, using your catheter to like help with urinary tract infection. The gentamicin issue was brought up, but also just flushing with normal saline. We can use that catheter going both directions. And then the other thing is there's a lot on the horizon. Neuromodulation, catheters, devices. There's a lot of stuff coming out there.
Any tips you have for people who are having a hard time getting catheters and supplies, and any
Ugh.
words for the insurance company? Magic words? Do you have magic words?
I don't know magic words. I just, I say try to partner with your clinician, because it makes me mad too. And I don't, it makes me very, very frustrated. So really try to partner with your clinician, because we as clinicians, we don't want you to have that problem. And we want to be a part of the solution as well. I will say this, like one of the new catheter companies I'm working with, the company is called Ori. They're developing a catheter that can be reused about 100 times, which is really great. So I'm really hoping that will be an option for people in the future, because it's not only better for the environment, but it helps relieve this problem.
Well, fabulous. This has been a fabulous hour. I wish we could stay another 6, 10, 12 hours. Could go on for this forever, from one bladder lover to another. So thank you so much, Dr. Groah. It's just been a delight, and we wish you nothing but success in all of your endeavors. And I hope to see you soon.
Thanks so much for letting me have the opportunity. Good luck.
Thank you.